So this next one is really to talk about the management of non-infectious uveitis. I do have some financial disclosures that might be relevant to this talk. Now, as I said in the first lecture, the challenge is to determine what you're dealing with, investigations, when to start treatment, and what should I use. And that's what the whole basis of this talk is. Okay, so again, always exclude infection. And then, is there a reason to start treatment? Okay, with non-infectious uveitis, a lot of it hinges on whether or not the patients have symptoms to warrant starting treatment. That's usually pain or reduced vision, or do they have sight-threatening complications as a result of their inflammation, which you want to try and prevent. So these might be immediate loss at presentation due to, say, significant vitritis, or it might be due to the development of vision-threatening complications as a result of untreated chronic inflammation. So we're talking about cataract, glaucoma, and CME, obviously. Okay, so therefore, if you have a patient who comes in with uveitis with reduced vision, we need to determine why they've got poor vision, okay? Is it inflammatory, like cystoid macular edema, or the degree of their vitritis, or with that case of the young boy with retinal vasculitis, is it due to that? Or is it due to non-inflammatory causes, such as cataract, vitreal debris, subretinal neovascular membranes, all of these things that can occur that you know will not respond to immunosuppression, as in these are permanent unless you do something further in some of these cases, okay? Because this will then determine what sort of treatments you're going to give them, okay? Now, what sort of treatments? Local or systemic? A lot of it depends on where the disease is. Is it unilateral, bilateral, or is it posterior segment disease? All of these things we need to consider. Got to think of the patient in front of you. The immunosuppressant that I would use in a 20-year-old man will differ from a 20-year-old woman who wants to have children, okay? Also, immunosuppression in a 20-year-old is quite different to immunosuppression in a 90-year-old, okay? Again, these are all things that we need to consider. And of course, patient expectations. One of the main things is that patients don't realise that we have no treatments for non-infectious uveitis that is curative. We only have treatments that keep it under control to keep them sighted until the disease may wear off on its own or die out on its own. Okay, and you obviously have to start to talk about side effects and risks. So these are all the things that we have to consider when we have a patient who comes in with uveitis. So how do we treat non-infectious uveitis? Essentially it's drops, shots or injections or pills. Okay, and that's what I'm going to be talking about here. So start off with a fairly basic case. A gentleman with established ankylosing spondylitis who has acute anterior uveitis, comes in with sudden onset discomfort and mild injection. He literally developed symptoms 2 hours ago, but he's had so many episodes, he knows that this is his typical uveitis. Okay, this is what you see. Not a lot of ciliary injection, maybe a few cells. Vision's still good. IOP a little bit lower in the affected eye. All right, so what are you going to do? All right, are you going to start prednisolone forte, which is the strongest steroid drop that I've got in Australia, 3 to 4 times a day with a dilator, 1 to 2 times a day, see him in a few days, because the iritis is pretty mild right now, should respond? Or would you hit him hard, pred forte every hour, as well as the dilator, and see him in a few days? Okay, think about it. Now, if you chose number 1, 3 to 4 times a day drops, okay, 1 day later he comes in, he says, my eye's a whole lot worse, okay, vision's down, he's got a hypopion now. So this now puts you in a pickle, okay? What does this mean? Does it mean that this patient has clearly worsened despite starting treatment of pred forte 3 to 4 times a day? Have I got the diagnosis wrong? Okay, have I missed an infection? Or is the patient being undertreated? Is he not taking his drops? Okay, and the question here is, this scenario probably would have been avoidable if you had actually hit the patient hard, okay? With regards to acute anterior uveitis, and you know it's non-infectious, you've got to go hard, all right? You've got to use the drops every hour, especially in a patient with spondyloarthropathy with an acute anterior uveitis. It also applies to patients with Behçet's. You've got to hit them hard, because then you know, if you just start them on a little bit of steroid drops or a little bit of oral steroid and they come back worse, you're stuck in no man's land. You're stuck in purgatory because you don't really know which way to go from there, okay? Whereas if you hit them hard and they get worse, then you know you've probably got the wrong diagnosis, all right? So you've got to hit them hard. Predfort is the most potent and effective eye drop that I've got here. I think it's similar here in Indonesia, but I'm happy to be corrected, okay? Always start at frequencies of one drop or 1 to 2 drops every hour by day. And if they happen to wake up in the middle of the night, they can put a drop in then too. A cycloplegic to really try and prevent posterior synex from occurring and prevent and to reduce some of that pain that the patients get from ciliary spasm. Okay, so hit them hard with the drops. Okay, we know there's side effects, but usually these don't occur until we keep them on steroid drops far too long. Okay, particularly in B27 associated uveitis. Okay, always consider that you've got the diagnosis wrong. Always make sure that they haven't got a history of herpetic disease. Okay, and that is the reason why we tend not to try and keep these patients on high doses of topical steroids for too long. All right, so B27 accounts for about 50% of all of our acute anterior uveitis in Australia. I know that the rates of B27 is lower in Asian populations, so I'd be very interested to know what your spread of B27 associated uveitis here in Indonesia is. It responds really nicely to intensive topical steroid therapy if you get them hard, if you get them early and you treat them hard, okay? Occasionally, you may require more aggressive therapy with periocular steroids or systemic prednisolone. That's usually in cases where the presentation has been delayed and your patient has therefore got spillover significant vitritis and cystoid macular edema. That's when you have to go for the next aggressive therapy. Now, B27 associated diseases, ANG-SPOND, inflammatory bowel disease, reactive arthritis, psoriasis, all typically cause acute anterior uveitis. Okay, unilateral often flip-flops, so flops from one eye to the other between episodes, but not always. Okay, so that's topical therapy that I'm going to put to the side, and I'm going to now move on to strategies beyond drops. So I'm going to talk about the injected therapies, systemic immunosuppression, and biologics. And my pointer has died, so I'm wondering if that it still works. That's okay. I can go without a pointer. All right, so common acute treatment regimens, okay, it's all about acute delivery of corticosteroid to control the episode the patient is having right in front of you, okay? That's periocular steroid, intraocular steroid, oral pred or IV. It all depends on the severity and where that inflammation is as to which one I'll choose. And then in patients where I know it's going to be chronic, okay, that's when I have to think about chronicity treatment, okay? You can't keep these patients on corticosteroids regardless of the form long term because we know they have side effects. And that's when we have to think about steroid-sparing therapy. So that's what I'm going to go through. All right, so the management approach, as I said to you before, depends on how the patient is presented to you. Unilateral disease is quite different to bilateral disease. Unilateral disease, short-term, local treatment is just fine, okay? Long-term treatment, though, you may combine the local treatment with a systemic steroid-sparing treatment. Bilateral disease, I'm less likely to inject, okay? A lot of patients don't like bilateral steroid injections because of the floaties and things. And that's when you talk about oral prednisolone. And if it's chronic, that's when you combine it with a systemic sparing agent. All right, so just to illustrate this case, a 66-year-old Caucasian gentleman, long history of bilateral presumed idiopathic anterior intermediate uveitis with cystoid, which you can see here on the angiogram. Now, the cystoid and the uveitis is responsive to the oral prednisolone. And the uveitis, the degree of inflammation, is well controlled after starting methotrexate and weaning him off the oral prednisolone. So he's on methotrexate alone, but despite this, he's got recurrent cystoid macular edema in the right eye without much inflammation. So then you sort of sit there going, okay, I'm going to need to do something further. What are my options? Okay, it's either go back on systemic systemic steroids, or consider injected steroids, okay? And so local injected steroid therapies is particularly useful for unilateral disease, unilateral cystoid like this gentleman has, okay, and intermediate posterior uveitis, or chronic posterior segment inflammation as initiating therapy whilst he's starting the systemic immunosuppression steroid-sparing agent, or as top-up therapy like this gentleman, where his inflammation is well controlled with a steroid-sparing agent long-term, and he's got recurrent cystoid, at which point I want to get rid of the cystoid and hope it settles in the longer term. Okay, now the one thing to be beware of is obviously patients who have advanced glaucoma or are known to be severe steroid responders. So what are our options? Okay, so these are the treatment strategies, and I'm going to really just talk about the injected therapies in this first half of this talk. Okay, so what are we talking about? So we're talking about periocular steroid injections and the implants and steroids. So periocular steroid injections, just to go through this, I generally use Triamcinolone. It's neat, easy, it's 1 ampule, 40 milligrams, 1 mil, and injected inferiorly. I usually use a transeptal approach, so through the skin, because I'm a feeler, but some people are someone who likes to see, then you can actually go through the fornix and actually view that. I like to know where the eyeball is with my hand. So this is how I usually do this. Infratemporal transeptal approach is what I normally do. You can also do a superior subtenons injection instead and go up above the globe. Now, this stuff does work. So periocular injections do work. This is Sue Lightman's data, which actually shows that the visual acuity does respond to this treatment. However, it does have side effects, okay? And I think we're very, very familiar with these: intraocular pressure rises, cataract, and as you can see here in this picture is the orbital fat prolapse that you can see here. Now, the problem with the superior subtenons is that you may avoid the orbital flat prolapse from the injection, but they can get a secondary ptosis. And I unfortunately, one of my first superior subtenons, I induced a ptosis in a 40-year-old lady who was very particular about her cosmesis. And so she ended up seeing an oculoplastic surgeon who told her not only did she need her eyelid done, but she needed a whole facelift. And so she wasn't very happy with me after that. So since that time, I've always done an orbital floor inferiorly. It's funny how we get scarred by our own personal experiences. But anyway, so that's periocular steroids. Now, if we move on to intravitreal steroid injections, there's either Triamcinolone, or you can actually then look at Triessence, which is the unpreserved Triamcinolone, and then Ozurdex. So I'm going to just start with Triamcinolone. I generally use a Kennicort. The preservative-free is Triessence, 4 milligrams, 0.1 mil. Okay, side effects are there. We know the IOP increases, okay, in up to around about 45% by some retrospective series, but also there's cataract, and with Triamcinolone, there's the issue of TAS. So TAS being sterile endophthalmitis as a reaction to the Triamcinolone. It usually occurs within 24 hours of your injection. The patient comes in and it's painless usually, and you just sort of see this sort of hypopian-like appearance. Sometimes that looks like crystals, but it is a definite reaction. Settles very quickly. It does not worsen, which is what you would expect with infection, and that's something that we always worry about. These are patients that I usually sort of keep under observation for 12 hours and see how they go, and they usually settle with intensive topical therapy, as opposed to infectious endophthalmitis, which is what we always worry about. They tend to get worse over time. So I observe them over 12 hours. Now, it was thought that this only occurs with the unpreserved form of Kennicort, but that's not the case. It actually has been described in Triessence as well. Okay, which moves us to Ozurdex, which is the dexamethasone implant. There's only been one trial of Ozurdex prospectively in uveitis, and that's the Huron trial, which was done many years ago. Patients were randomized from sham, so this was a controlled trial versus 2 forms of Ozurdex. And unsurprisingly, I mean, we know if we don't treat uveitis, it doesn't get better, and that's what the sham group did, as opposed to the patients who got the dexamethasone implant. Surprise, surprise, they actually got better. So essentially the 0.7 milligram dose is the most effective. That's the one that's now available as Ozurdex. Their rate of ocular hypertension was around about 40% in that study, okay, and cataract was in a small number, but this was only a 6-month study. All right, so the question here, though, with injected steroids is which one is better? Triamcinolone, periocular Triamcinolone, or Ozurdex, okay? Now, the only way to test this is with a prospective randomized clinical trial, and that's exactly what the POINT trial is, okay, which was recently published late last year. So I'm just going to quickly go through the results of the study, because this is the question we all have: which is better? All right, so this was a study for uveitic macular edema, where the patients could either have quiescent uveitis, like my patient that I presented just before, with cystoid macular edema, or active uveitis, okay? And what we wanted to know is whether or not intravitreal Triamcinolone or Ozurdex was better than periocular steroid injections for cystoid macular edema, and also see whether or not the DEX implant was non-inferior to intravitreal triamcinolone, with the secondary hypothesis being that the dexamethasone implant would have a lower rate of intraocular pressure rise than the intravitreal triamcinolone. Okay, because I don't know about you, but it's certainly been promoted quite heavily that Ozurdex doesn't cause that pressure rise that we see with triamcinolone. All right, so as I said, multi-centre trial, and I'm pleased to say that Australia, or Melbourne, was one of the recruiting centres for this trial. We had a spread of patients here that you can see here, and you can see here that the majority of patients, or a large number of patients, required more than one injection over the 6-month period of the trial. All right, now, if we go on to the results, okay, you can see here, do you have a, okay. Okay, thank you. You can see here, along here, that by week 8, all of them resulted in a reduction in central macular thickness from baseline. Okay, so with regards to central macular thickness, they all work. All right, but if we actually compare them up, okay, intravitreal versus periocular, intravitreal is better. Ozurdex versus periocular, Ozurdex is better, okay, than a periocular steroid. But if you compare Ozurdex with triamcinolone, no difference, okay? Both of them are just as effective for reducing central macular thickness, okay? And this is just a graph of that. This is Ozurdex and intravitreal as opposed to the periocular. They all get better, but the injected intravitreal injections are better. If we look at resolution, similar sort of graph. All right, now, visual acuity, okay? Change in baseline, again, all of them, they all got better, but if we actually compare triamcinolone versus periocular, again, triamcinolone is better, Ozurdex is better than periocular. No difference between Ozurdex and intravitreal triamcinolone with regards to vision gain. All right, now let's get to the interesting one, intraocular pressure rise. Now, if we just look at overall, okay, all of them cause raised intraocular pressure, all of them, all right? 20% periocular, 30% triamcinolone, 40% Ozurdex, okay? Let's compare them up. Firstly, if we just look at rises in intraocular pressure greater than 10 millimeters mercury from baseline, okay? Ozurdex was found to have a much higher risk of doing this than the periocular, okay? Not so for triamcinolone. And if we compare the two of Ozurdex versus intravitreal, no difference. No difference at all. If we look at the higher rate of an intraocular pressure greater than 24 millimeters of mercury, okay, both intravitreal and Ozurdex cause you're more likely to get a higher rate of intraocular pressure rise with the intravitreal injections over at the periocular. All right, and again, no difference between Ozurdex and triamcinolone with regards to intraocular pressure rises. All right, and this is just a graph of that. You can see here the intraocular pressure rise is pretty much the same between those two intravitreal preparations. All right, so the conclusions, intravitreal triamcinolone and dexamethasone are superior to periocular triamcinolone with regards to degree of reductions in central macular thickness and degree of visual acuity gains. But there was no difference in the rate of intraocular pressure rises between intravitreal triamcinolone and the Ozurdex implant. Absolutely no difference, okay? This is quite contrary to all of the retrospective data where a lot of our colleagues around the world have been promoting Ozurdex as being the safer implant with regards to intraocular pressure rise. And it just shows you how biased we are to the next new thing, okay? I know where I am on this curve, but often when these first things come out, we are sometimes maybe a little bit prone to a bit of fake news. Okay. All right. So based upon these, you sort of sit there going, okay, well, why don't I just inject everybody with posterior segment inflammation and the complications? Why don't I just treat them all with intraocular steroid injections and not worry about the rest of it? Just a few words of caution. Number one, you can get a nasty surprise. You might remember this slide that I presented earlier. This is intraocular syphilis, okay? Placoid, multiple placoid uveitis as a result of one of my colleagues injecting triamcinolone into a patient who presented with intermediate uveitis. okay, got a very nasty surprise. Loss of vision down to less than 660. Okay, again, you've got to ask those questions and think about syphilis. You've already seen that slide. Number 2, okay, is the findings of the MUST trial, another multi-centre trial. Some of you might have already heard about this using the fluocinolone implant, a randomized trial between systemic immunosuppression versus having these implants put in over a long period of time. Okay, these implants last up to 3 years. It's like having steroid inside the eye for 3 years. Okay. Now, there are side effects, cataract and glaucoma, as you would expect. Now, all the groups, systemic immunosuppression versus the Retisert implants, had an improvement in vision. Okay, they all improved. Okay, the implant group did initially do better in the first 6 months, but by 12 and 24 months, that advantage, that initial advantage was lost. So they were very similar by 2 years. Okay, and with regards to cystoid, this was largely due to cystoid macular edema, where the implant group had less CME at 6 months. But again, significance was lost by 2 years. There are significant complications from the Retisert implant. Okay, 100% get cataract by 24 months virtually. 91%. 50% develop glaucoma by 24 months, and a large rate of these required surgery. Okay, so there are significant risks with this. Okay, and at 5 years, we've now got 7-year data. At 5 years, the implants are starting to fall off. Okay, requiring further surgery to actually retrieve the implant. And we also know that by 7 years, what we found was that the systemic immunosuppression group for these patients did better than the implant group. And the conclusion at 7 years, and I'm going to read this word for word, is that uveitis relapses, once the local therapy wears off, are more severe and more likely to result in irreversible damage than the lower grade relapses we have when we wind down systemic immunosuppression. Okay? Hence the need for caution if you are considering using local injected therapies as solo treatment for long-term persistent uveitis. Okay? This is the role of systemic immunosuppression. All right, now I mentioned at 5 years the Retisert implants are falling off. One thing that's coming on the horizon is Iluvien. I don't know if it's landed in Southeast Asia. It certainly hasn't landed in Australia yet. It's basically like the Ozurdex implant, only with fluocinolone, lasts 3 years. But again, same thing, it will have the same side effect profile. And again, there is that caution with regards to using this long term. All right, there are other intravitreal therapies, anti-VEGF, methotrexate, sirolimus for non-infectious uveitis and cystoid macular edema. Now, the first two, the anti-VEGF and methotrexate, are currently under trial, for which my centre's part of, comparing ranibizumab, Ozurdex and methotrexate for the treatment of uveitic macular edema. Okay, so that trial's still ongoing. We'll have some results to you hopefully in the next couple of years. Okay, so I'm going to leave injected therapies to the side here and now go on to systemic therapies. You might remember this 35-year-old lady with sarcoidosis. You know she's got granulomatous panuveitis. You know this is not going to go away in a month. Okay, this is long-term, significant disease, and it's more than just drops in this situation. Okay, and this is when we have to start talking about pills. We're talking about prednisolone, steroid-sparing agents, and biologics, which is what I'm going to try and cover today. All right, so prednisolone, we all know this, okay? It's either oral prednisolone 1 milligram per kilogram or IV methylpred for severe disease. Severe disease are usually put into this category Behçet's, Behçet's and VKH. I'll often admit these patients for their acute flares. Okay, strongest, most effective, but has side effects. Okay, 99.9% will get side effects. Okay. And this is just a small fraction of the side effects these patients will have, okay? And I would argue the 0.1% who don't have side effects are the ones not taking the medication, all right? It's that prevalent, okay? Long-term uses of doses greater than 5 milligrams a day is not recommended. 7.5 milligrams is thought to be the safe dose, but that dose keeps getting lower and lower and lower. And so as soon as you've got patients who've got ongoing inflammation, despite beyond 5 milligrams a day, you need to think about steroid-sparing agents. What do these do? They suppress the immune system. they take longer to act. So usually you have to start the methotrexate or steroid-sparing agent at the same time as your prednisolone, wean off the prednisolone over a long period of time, so a few months, at which point it's hoped that the steroid-sparing agent will maintain that gain, okay? Adding the steroid-sparing agent doesn't boost the amount of anti-inflammatory action on the uveitis. It maintains the gain of the corticosteroid that you're using, whether or not it's systemic prednisolone or injected therapy, okay? They all have side effects, these steroid-sparing agents, but it's far less than that for steroids, okay? It's around about 30, 40%, depending on your patient. So what are we talking about here? We've got the antimetabolites, methotrexate, azathioprine, mycophenolate. We've got the T-cell inhibitors, cyclosporin and tacrolimus, okay? And you've got the alkylators, which actually I have to admit I don't really use very much anymore, despite the fact that they're cheap because of their toxicity profile. All right, now there are some really good guidelines in the literature with regards to systemic immunosuppression, and I'll just leave up these two references here. It's a really nice skate through how to work up your patients prior to starting systemic immunosuppression, what sort of target doses you ought to be looking for. So I highly recommend that, you know, if you are managing patients on systemic immunosuppression, that you have a look at these two guidelines articles, because they do sort of raise it very nicely or go through it very nicely for you. And if you like the references after the lecture, I'm happy to give them to you. Okay, now managing systemic immunosuppression is best done with the physician, okay? It's much easier if you've got a physician who knows how to work up your patients, is kept up to date with regards to new changes with our understanding of using these medications. And it's also a good way of actually keeping yourself updated too with working closely with a colleague. And so certainly in Melbourne, I have two rheumatologists and immunologists on speed dial, and they've got me on speed dial, where we actually just talk and communicate about how our patients are going. Now, this particularly applies to patients with medical comorbidities. That I don't manage all of my patients in hand with a rheumatologist, but certainly most of them, okay? These patients require frequent monitoring. They need bloods, initially 2 weekly, then monthly, then 2 monthly, okay? And they do need specific workup for certain medications, which I'll go through. So the antimetabolites, methotrexate, target dose is about 10 to 25 milligrams a week. My target dose for most of my patients is 20 milligrams a week, okay? It is teratogenic. All right, so you have to, that's why I don't generally roll this out to my young patients who want to start families, male or female. Azathioprine, 1.5 to 2 milligrams daily. Now, in the Asian population, you've got to be aware of TPMT deficiency. I do screen for these patients because they are at risk of pancytopenia as a result of the azathioprine. And if you know your patient is TPMT heterozygous, you still can use the azathioprine, but at a lower dose. If they're homozygous, you cannot, okay? And you'll end up sending your patients to ICU. Mycophenolate, again, 1 to 1.5 grams twice a day, teratogenic, okay? Cannot be used during pregnancy. And when I say teratogenic, these patients must abort if they get pregnant on these medications. Okay, so the question is always with antimetabolites, which is usually the first step of treatment for steroid-sparing agents, is which is best? Methotrexate, azathioprine, mycophenolate, okay? And this is actually the subject of another randomized controlled trial, clinical trial that we were involved in with the NIH in the United States, where we compared methotrexate versus mycophenolate as a first-line steroid-sparing agent. Now, what we wanted to do is work out which one's better, okay? And as I said, it's an international study. Just look at the target doses here, 25 milligrams weekly oral methotrexate versus 3 grams of mycophenolate. So top doses, highest doses in this trial, okay? We had 407 eyes of 216 patients. Most of them had bilateral disease, and you can see the spread here. Now, currently the manuscript is under review with JAMA, so at the moment I can't actually show you the results, but I can certainly let you know that the initial primary paper has actually shown the cheaper drug, methotrexate, is actually better than mycophenolate, which is quite different to how we've always thought in the uveitis community. It was always thought that mycophenolate would be better than methotrexate. But we actually found with this randomized trial that's not the case. And in fact, if you fail mycophenolate and switch to methotrexate, you are more likely to respond to methotrexate than the other way around. So if you fail methotrexate we found these patients were also likely to fail mycophenolate. So that's already changed my practice, is that if I've got a patient who's failed mycophenolate but haven't tried methotrexate, I'm more likely to switch them over. And if they failed methotrexate, I often don't bother trying with mycophenolate if the reason for failing methotrexate was not due to complications or intolerance but due to inefficacy. Okay, so that's already something to take into account, because methotrexate is cheap as chips. Okay, mycophenolate's really expensive. All right, so these are things that we have to consider. All right, so T-cell inhibitors, we're talking cyclosporin and tacrolimus. Okay, these are the target doses. Beware in patients who have diabetes, renal failure, hypertension. Okay, renal failure and hypertension will occur eventually, unfortunately, in patients on cyclosporin. So you just have to beware about long-term usage. And this is where I usually get a physician to actually co-manage these patients because of the long-term morbidities. Alkylators, we're talking cyclophosphamide or cytoxan or chlorambucil. These damage DNA, okay? This is how they work, okay? Extremely toxic, okay? These patients can drop their cell counts very quickly. There is a risk of bladder cancer. There is a risk of skin malignancies. This is toxic stuff, tends not to be used all that much anymore, perhaps still in some OCP or MMP patients with cicatricial pemphigoid. All right, now, moves on to biologics, okay? What are biologics? They're therapeutic proteins designed to block specific activity of immunoreactive molecules, okay? So they offer that promise of targeted therapy, very similar to all the anti-VEGF therapies that we use in diabetes and age-related macular degeneration. Now, the biologics in uveitis, there's a stack load here. There is no way I can go through all of these in this lecture because I'm pretty sure I've already sent half of you to sleep. I'll send the rest of you to sleep if I try and go through all of these. Okay, so I'm just going to go through a couple of the ones that are now on the horizon about to come here, or if they're not already. Okay, so this is one of my long-standing patients, 35-year-old gentleman when I first met him. We were both young when we first met each other, and he had Behçet's disease for many, many years by that stage. He had very, very aggressive disease. Despite remaining on a lot of prednisolone, he failed mycophenolate, methotrexate, and cyclosporin. This is him, despite various combinations of that and prednisolone, okay? So he lost his left eye as a result of aggressive disease, okay? And he had recurrent posterior uveitis with retinitis, severe steroid responder to steroids, local steroids. So again, really made it really difficult to control. Had this flare-up with these areas of retinitis and panuveitis in his one remaining eye, despite cyclosporin, methotrexate, big doses, and 25 milligrams of prednisolone. Okay, so this is not what you want, right? Only-eyed patient who's going blind in his only eye, all right? And so what we did is I admitted him to hospital, pulsed him, and begged the hospital to fund his Humira, okay? And since that time, we're now 7 years down the track, he's been kicking goals, okay? His uveitis has remained quiescent. We were able to stop his prednisolone for the first time in a decade. He lost a whole stack of weight. He's just on methotrexate now on a low dose, which is what we usually do. And he's no longer clinically depressed, okay? Still working, still supporting his family. So a win. Doesn't always happen in uveitis. Okay, so what is Humira? It's a tumour necrosis factor inhibitor. TNF is one of the key pro-inflammatory cytokines, okay, and has been found to have a role in uveitis in animal models. So it seems to make sense that it would help in uveitis. Humira is the one that's subcutaneous, given every 2 weeks. It's fully humanized, and so it's very easy to dose as opposed to some of the other TNF inhibitors that we know is around. Now, adalimumab is also one of the few treatments that has been subject to a randomized controlled trial in uveitis, okay? And this was recently published, or not recently now, it's a couple of years old, in the New England Journal, okay, of the Visual 1 and 2 studies. And these are patients who had active or inactive disease. And you can see here, again, it's an international study trying to get up the numbers to actually get significance. And I'm, again, happy to say that in Australia we were involved in this too. Now, all the patients in this study were placed on high-dose oral prednisolone if they had active uveitis, and then put on Humira and see whether or not their uveitis remained quiescent. And with regards to the inactive study, they basically started Humira and see whether or not they could get off the pred without relapse. All of these patients had non-infectious, intermediate, posterior, or pan-uveitis. Exclusions, the number one thing to think about with these patients with intermediate uveitis, they had to have no signs or symptoms suggestive of associated multiple sclerosis. Okay, the reason for that is because the TNF inhibitors will worsen demyelinating diseases. So this is something you have to consider in all patients with, when you're considering TNF inhibitors. The other thing also is reactivation for tuberculosis, which is something that's very, very relevant here in Southeast Asia. And so basically, if your patients have been exposed to TB, they need treatment before they actually start Humira, and you also have to also be very aware of reinfection in these patients. Now, with this study, it was there was multiple primary endpoints with regards to clinical outcomes. But just to cut to the chase with regards to results, you can see here that there was a far lower risk of failing treatment. It was reduced by almost half in the Humira group as opposed to the placebo group. So we found that it worked, and the time to failure was doubled. So you were less likely to flare, and if you were to flare, it happened at a much later time point than those patients who were on placebo. Okay. However, I will highlight the fact that not all patients respond. There is still a failure response. So it's not the cure-all, but it's certainly useful. Okay, and this is with the inactive study, again, similar sort of curve. All right, so we always talk about, okay, this is a randomized controlled trial. How about real-world data? There are some studies here, and one of them was one that we did here did in Melbourne in Australia, and it was retrospective. And just to basically just show you, we didn't have a lot of patients, but a big spread of the types of uveitis involved, okay, including JIA, a lot of Behçet's patients. And what we found was similar sort of results. Patients could get off their Prednisolone by and large, retain their vision, and essentially similar sort of curves that you saw with regards to time to failure in both the active and inactive groups that you saw in the randomized controlled trial. So even in real world situations with more aggressive, less sort of clean-cut cases of uveitis, Humira does still tend to work. Okay, so this is despite the fact that our patients had more chronic disease, they were more likely to be on multiple treatments and failed previous treatments, we were able to validate or replicate the visual studies. Okay, now I know there are lots of other TNF inhibitors around, etanercept or Enbrel, Tocilizumab and Golimumab. These are probably just as good as Humira, but of course have not been studied. Enbrel is different, okay, because essentially it's always asked, does it really matter which TNF inhibitor we put them on? Okay, and it does if it's Enbrel, okay? Enbrel tends not to work. And that is similar to in Crohn's patients, okay? Now, one of the other things that can happen if your patients have TNF inhibitors for other forms of diseases is paradoxical inflammatory conditions. So they may get new onset rheumatoid in Crohn's patients, or they may get new onset uveitis. In those situations, it's often asked whether or not they should switch medications. And I often sort of say, well, why not, so long as it's not Enbrel, okay? Intravitreal TNF inhibitors has been described. It's not something that I would advocate only because of the risk of secondary inflammation. There's been quite a few publications actually advising against doing this. There are some new studies now that have actually been using Humira intravitreally. I would say watch this space with regards to doing that without good evidence. All right, so I'm going to go back to our young patient with sympathetic. He actually did very, very well with aggressive inflammation, anti-inflammatory treatment. We actually had him on Remicade because this is 17 years ago when I first met him. It shows how old I am. But anyway, he is now in his 20s. And the question is, how long do we treat him for? Okay. Humira is really, really expensive, and so is Remicade, okay, because this is an IV infusion. And the question we all have is here, well, it's really expensive. How long do we treat him for? Only I. What do we do? Okay, and it comes to cost effectiveness, and this study might have come up on your horizon recently, published in Ophthalmology actually earlier this year, using the Sycamore data, which is Humira in JIA uveitis. So not sympathetic, not only eye patients, but patients with blinding disease. And they actually found, hold on to your hats here, the cost effectiveness ratio was £129,000 per single QALY. That's enormous. Absolutely enormous. And no health system in the world, I think, can afford this. okay? And in fact, from the study, it said there would need to be a drug discount of 84% to meet the £30,000 per year quality threshold. And I guess what I feel that in the medical profession, these medications are great, but I think we need to push back sometimes to the pharmaceutical companies and sort of say, look, this is ridiculous. Sharpen your pencil, okay? Reduce the cost of some of this stuff, because we can't put all of our patients and continue them long-term on this medication. Anyway, I'll get off my soapbox and continue the talk. Okay, a few more biologics. Rituximab, anti-B, okay, CD20, okay. It is very effective for scleritis and orbital inflammatory disease, okay. And this is just one case of refractory scleritis, and after 2 infusions of rituximab, settled, okay? This patient failed cyclosporin, mycophenolate, azathioprine, methotrexate, and was a steroid responder to subconjunctival injections. So he is very happy. Now, essentially, there have been some studies. One of them is one that I did quite a few years ago, which found that, rituximab is a good treatment for scleritis and non-infectious orbital inflammatory disease in aggressive cases. And this is another case. Another posterior scleritis flare responding to rituximab. Another medication, or another biologic I'd like to raise with you is Tocilizumab. Actemra blocks IL-6, and the reason I'm bringing it up is because it's actually been found in some studies to be very good for treating cystoid macular edema, particularly in steroid responders. Okay, interferons, I'm sure you've all heard, it's not new. It's used a lot in Behçet's disease, and particularly, again, in cystoid macular edema. However, interferons do have side effects. Okay, even though, this is in Behçet's, it's particularly effective, but it does have significant side effects, okay, with a high rate of discontinuation because of the side effects, and as a result, it tends not to be first-line treatment because it's not as well tolerated by some of the TNF inhibitors. Okay, so I think, I'm just thinking we might hold there. I can show you this case, but this is really a poor lady who, I'll quickly go through it, is a lady with rheumatoid, a lot of immunosuppression with tofacitinib, which is a JAK inhibitor, another new form of biologic, comes in with quite severe uveitis and retinal vasculitis, occlusive retinal vasculitis. And what we found was she had CMV retinitis, and this is sort of what it looked like after a week of therapy. That's probably easier to see. This is her angiogram, and you can see here that she's pretty much pruned off her whole retinal vasculature as a result of her CMV uveitis. Okay, and really the problem is that she's got the CMV retinitis because of her immunosuppression. But then when we stopped her immunosuppression, she couldn't get out of bed because of her rheumatoid arthritis. Okay, and so now we've got this horrible sort of seesaw between what should we do to keep her rheumatoid arthritis under control and what do we do to keep her sighted. Okay. She does highlight that CMV retinitis in otherwise immunocompetent non-HIV patients looks different to what we normally would look for. And we don't really know how to treat these patients long term because we can't stop their immunosuppression. Okay, and so we've got this inenviable seesaw between too much immunosuppression and CMV retinitis and too little immunosuppression, and she can't get out of bed from her underlying disease. Okay, so biologics and infections is something we have to be aware of. TNF inhibitors, mainly it's TB that we have to worry about. With regards to the JAK inhibitors, it's herpetic disease, as highlighted by my patient. Okay, so just the last word on biologics, okay? They sound great, they're new therapies, but surprises do happen. It's sometimes hard, we get bad infections where it's hard to balance out what to do, okay? And they're really, really expensive. Okay, and so we really have to justify the use of these medications and not be sort of, I guess, too swayed by the promise of the new. Okay, so we've talked about some of the common pitfalls: inadequate history, inadequate examination, not looking at the fundus, under treatment, like the B27 patient I showed, and failure to reassess when treatment fails. Some take-home points: always think infections. Remember, local therapies are only short-term treatment. Okay, never leave a patient on high-dose oral prednisolone for too long, and it's always nice to co-manage patients with systemic immunosuppression with a physician. Okay, thank you very much for sticking with me for that long. Okay, any questions?
Thank you. That was very interesting, and I hope all of us can digest everything. Hopefully,
Tour de
everything.
force.
We still have one more very interesting session, the last session of the day, which is cataract surgery. And we take a short break, taking one or two questions from the audience about management of uveitis. Dr. Agung.
Okay, thank you, Dr. Bayu. Thank you, Professor Linder. My name is Agung. As we know that in the biggest problem is we use like a monoclonal antibody, in example, infliximab, rituximab, and adalimumab is the high risk of the tuberculosis reactivation. My question is just one: when we can start the therapy with the my patient with the history of the tuberculosis? Thank you, Professor.
Yeah. So basically the guidelines that we basically adhere to is those from the Australian Rheumatology Association. They say that you need to start full therapy for a minimum of around about 6 to 8 weeks before starting the TNF inhibitor. So, and it's not isoniazid prophylaxis. They need full, triple or quadruple therapy. At least, 6 to 8 weeks. Ideally 3 months. Before you start the TNF inhibitor. Now, in these sort of situations, it's not only co-managed by the ophthalmologist and the rheumatologist, we also have the infectious diseases physicians on board as well. So these patients are a much higher risk. And I guess, the fortunate thing for me in Australia is that we don't actually have a high rate of endemic TB in our population, whereas it's much more of an issue in Southeast Asia where you've got high endemic TB within the population. So there's always that risk of co-infection or secondary infection later on down the track. So that's something I think that, I'd be interested to talk to your ID colleagues.
Maybe you want to...
Oh, thanks.
We're taking one more question before moving to the next session. Are you okay?
Thank you for your fascinating presentation. So my name is Karina, and I would like to ask how long would you recommend cycloplegic agent use in uveitis, and is it recommended to use it for a longer duration as uveitis tends to relapse?
Mm-hmm.
Thank you.
Yeah, so I only use the cycloplegic in acute anterior uveitis generally, and I only use it for a few days after I know that the inflammation is settling. Okay, and you generally get a feel for whether or not the inflammation is settling or whether or not the patient's compliant. It's only just in the acute initial phases of symptoms, and I don't continue it for too long because it's quite visually disabling in young patients because they can't accommodate and they find it hard to work. So as soon as the inflammation looks as though it's settling, there's no hypopia, and there's not a lot of flare, that's when I'll actually just stop the cycloplegic. Yeah, so it's less than a week that they'll be on it, only a few days. So I don't keep them on it for weeks and weeks and weeks. Okay. All right. The last talk's very short.
Let's move to the last session.
Okay. All right, so cataract. Common complication. All right, so cataract, we know, is a common sight-threatening complication of uveitis, and so we have to deal with it. All right, so how do we deal? So you remember my lady, okay, with sarcoidosis? Slightly different lady, but I've reused the pictures. So essentially, 12-month history of bilateral granulomatous uveitis, secondary cystoid, was managed by someone else with just intravitreal triamcinolone, and complaining of worsening vision in her left eye despite the triamcinolone, and this is her, okay? So she's got posterior subcapsular cataract, vision down to 636. All right, so what are you going to do? Are you going to find out why she's got the chronic bilateral uveitis? Are you going to check whether or not her uveitis is still active before taking out her cataract? Are you going to maximise the management of her uveitis first? Are you just going to take her cataract out? or all of the above? All right. Okay. So you ask her those questions that I said in the previous talks. Okay. She has that rash that I described. She's got intermittent inflammatory arthritis. She's got the cough. She's got sarcoid, biopsy proven. All right. And she says, I always need an injection for my uveitis every 3 months. Okay, so already that's ringing alarm bells because that's the reason why she's got that posterior subcapsular cataract. Probably could have been prevented, actually. She'd actually started systemic steroid-sparing agents earlier. All right, so what did I do? I commenced her on mycophenolate. Okay, her requirement for the Triamcinolone injections ceased after 6 months. Okay, so the first time she didn't need recurrent injections. I scheduled cataract surgery after 3 months of quiescence, and because of her history of cystoid, I also gave her Triamcinolone at the time of surgery. Okay, she did really well, okay? And so you sort of sit there going, okay, why should I worry about surgery in patients with uveitis? Well, it just so happens you've got to worry a lot, okay? The reason to worry is because we know surgery is a pro-inflammatory event anyway in patients without uveitis, let alone in patients with uveitis. They are more likely to relapse, they're more likely to get posterior synetes to the anterior lens capsule, and a high risk of post-op cystoid macular edema, okay? Now, a lot of this data is old because there's not a lot of studies out there. They're all retrospective, but this is the risk. What is the relapse rate? At least 15%. I would say it's higher. It's particularly within 6 months of surgery, and there are certain diseases where you have to look out, and the big one is Behçet's disease. These are at high risk of relapse after surgery, and if you look at the visual outcomes, you can see here the poorest visual outcomes are in patients with Behçet's disease. The other ones to look out for is VKH, sympathetic, and JIA. Unsurprisingly, these are the chronic forms of uveitis that we know are associated with poor visual outcomes anyway. So if you're going to do cataract surgery in these patients, beware in these patients. So what are the other risk factors? Basically, it's all about pre-op management, okay? Whether or not they were given any steroid pre-op and post-op, this is systemic, or whether or not they had active disease. Huge differences in the relative risk. If you have active disease or cystoid, you're in trouble, okay, pre-op. You want to maximise these things, recognise that these are poor visual predictors, look for it and deal with it, okay, and that's what I'm going to talk to you here. So when you plan surgery in uveitic eyes, it's all about pre-op planning, meticulous surgery, and close follow-up. Okay, so I'm going to go through each of these. Pre-op planning, we're talking about timing, adequate control of the inflammation and cystoid pre-op, realistic patient expectations and the fact that they have to keep coming to see you post-op as well, okay, and there's a bit of treatment on their side of the bargain, and obviously peri-operative treatment in intraoperative planning. All right, so timing. We always say the rule of thumb is ocular inflammation has to be quiescent for a minimum of 3 months prior to surgery because that's going to give you the best visual outcomes. And that's been shown by lots and lots and lots of studies here, as well as a recent meta-analysis by John Kempen. All right, so what is quiescence? Okay, basically it's aimed for 0 to 2 cells in the AC and very little flare if you can. Look, basically try and get no cells in the AC. Flare is inevitable in chronic disease. So essentially just aim to control it as best you possibly can, and also that applies to the cystoid macular edema. All right, control the inflammation, okay, particularly in those Behçet's patients, okay. Consider systemic immunosuppression if they're not already on it for at least 3 or 6 months prior to planned surgery. Treat any cystoid pre-operatively. Get that under control and treat again at the time of surgery if the timing is right, okay. All right, have realistic expectations. That's your side of things as well as your patient. Look for the blinding complications that aren't going to get better after surgery, okay? Look for the scar. Look for the macular atrophy from chronic cystoid macular edema. Counsel your patient appropriately, okay? Because an angry patient day one post-op is not going to come back to see you, okay? And that could be to their detriment, all right, if they've got ongoing post-op inflammation. All right, again, you've got to talk to them about post-op expectations, the risk of flare-up despite your best management, and the need to keep coming back. all right? And also know that they have to be compliant with the treatment they give you, that you give them, despite the fact that it might be hourly Predfort, it might be high-dose oral prednisolone. They need to ride this through with you, okay? Pre-op planning. Assess, look for all of the things that's going to make your surgery difficult, okay? Band keratopathy. You may need to remove the band at the time of surgery just to see what you're doing, okay? Is there conj scarring, okay? Are you going to be able to get your speculum in? Plan about what sort of, do you need to order in a different speculum to the one that you usually do? What does the pupil look like? Are there synetes there that you're going to have to manipulate? Are you going to use a Myogin ring? Sorry, that's a typo. Myogin ring, or are you going to use hooks? Okay, I will use a ring if I've got a deep AC, but if I've got an intumescent cataract with a shallow AC, I use hooks. Okay, it's much easier to manipulate, and the ring I'm more likely to bust the capsule just trying to put the introducer in. Okay, and that's despite the use of heel on GV. So again, also intumescent cataract, use a denser viscoelastic. Okay, white cataract, okay, I'm going to need to use Vision Blue. Okay, and again, be prepared. It's all about being prepared. Peri-operative treatment, okay, so if they've got anterior uveitis, I will increase the topical steroid. If there's a lot of anterior segment manipulation of the iris, I will consider putting in intracameral triamcinolone, okay, to settle the eye down in the immediate post-op period. If they've got a history of cystoid macular edema, I will either put them on systemic steroid or I'll put them on intravitreal triamcinolone at the time of surgery, okay? Now, which is better, systemic steroids or intravitreal triamcinolone? No one really knows which one's better. Basically systemic steroid is the gold standard, but we know it's got side effects, poorly tolerated by most. And so there have been recent studies that have shown that you can get comparable results with intravitreal triamcinolone. And these are the studies here. I'm not going to dwell on it because of time, but essentially that certainly has sort of moved, well, certainly in Australia, we've moved more towards local therapy at the time of surgery rather than, prolonged courses of high-dose oral prednisolone. The other thing you need to consider is which intraocular lens, okay? Acrylic, obviously. But if you've got a patient who you know gets quite robust inflammation that's going to contract down your capsule, think about using a 3-piece and not a mono-piece or a single-piece lens. Obviously, avoid silicone lenses. Now, specific treatments requiring more special sort of treatment, infectious uveitis. So if you're going to treat a patient with HSV or VZV uveitis, think about using at least topical acyclovir if you can get it, or systemic Valtrex. Toxo, you might consider prophylactic antiparasitic treatment if you've got posterior disease, because there has been one study that has suggested a relapse rate of about 1/3 in the post-operative period in patients with toxo. With regards to non-infectious uveitis, I think really beware of Behçet's disease patients. If they've got active disease, systemic or ocular pre-op, you're, be prepared, you're getting into tiger country a little bit, because the activity of their disease pre-op is the best predictor of how they're going to go post-op. So in some severe cases where I have to do the surgery, I will actually inject them on the steroids, maximise their systemic treatment and put them on oral prednisolone as well. Might be a bit of overkill, but it's better than feeling sorry for yourself and your patient post-operatively. With JIA, there has been a move towards putting lenses in, and I would have to say that I generally don't leave these patients aphakic anymore. Fuchs is another one. Initially, we all know that their treatment pre-op is not all that important. We only treat the complications. Cataract surgery in Fuchs, though, can sometimes trick you. I generally put them on some steroid drops pre-op, just 5 to 7 days initially. And I counsel my patients that they may require long-term topical therapy post-op because of their tendency for them to get deposits on their lens, okay, anterior surface of the lens, which can be visually disabling, but does respond to topical steroid therapy. The other thing with Fuchs is beware of the fact that they tend to bleed, okay, and so be very careful about inciting a high femur in these patients. That will make your surgery tricky. A bit less now with better fluidics with the phaco machines, but it's just something, don't manipulate their iris too much because you might just get yourself into a bit of trouble. Post-op, they can get very high IOP spikes, so be very careful there. And again, as I said before, beware of the anterior IOL deposits, and these patients may require long-term steroids post-operatively. Now, post-op care of these patients, close follow-up is important. Good compliance is important. You need to keep the inflammation under control as best as you can, okay? Major causes of poor vision post-op are due to chronic uveitis complications post-operatively, okay? Inflammation and cystoid after cataract surgery in these situations is often, because it's usually short-term, is often best managed with local injected therapies. Post-op care, be aware of expected outcomes with certain diseases. JI Behçets, again, tend to have poorer outcomes. Again, good counselling and meticulous attention to their inflammation. So, just to conclude, almost just on time. Okay, ideally, inflammation should be controlled at least 3 months prior to surgery. Do whatever you have to get them there, all right? Pre-op planning is vital, okay? If you've got a patient with chronic uveitis, consider systemic immunosuppression pre-op, okay? Give additional therapy if the specific disease requires it. Beware the Behçets patient, beware the JIA patient. These are the two patients that I would generally put them on systemic corticosteroids at the time of surgery in the peri-op and post-op period, in addition to anything that they require locally as well. Again, bearing in mind their risk of glaucoma, okay, and close follow-up post-operatively. Thank you very much.